Hello everyone, welcome to HIM 216. This is a continuation of the lectures for Chapter 6, and this is Lecture 10 of 12. In your textbook, we're on page 127. We are beginning with Guideline B3.12. This guideline talks about the difference in restriction and occlusion. And I want to refer you back to page 111, where we talk about these two root operations. These are root operations that alter the diameter or route of a tubular body. So these types of procedures include bypasses, like a cardiac bypass or a gastric bypass, and then also dilatation. We can have an esophageal dilatation. We can actually have other types of dilatations when a PTCA, percutaneous transluminal coronary angioplasty, is done and they put in a stent. That root operation is dilatation. When we're talking about occlusion, this is when we completely close the orifice of a tubular body. Think tubal ligation. You don't want to have your ovary just partially blocked. If you're having a tubal ligation, you want that fallopian tube completely occluded so there is not a chance that an ovum can get through to your uterus. You do not want to become pregnant. So you want both of those fallopian tubes completely occluded. Restriction, however, means that we just partially close off a tubular body part, and the example of this is a Nissen fundoplication. This is a procedure that is done where the esophagus meets the stomach, and because the esophagus is not has expanded, it allows stomach acid to go back up into the esophagus, and this is extremely painful. Patients have a very hard time eating, and so they go in and they actually bring the stomach up around the base of the esophagus and make that esophagus smaller. And I have actually seen instances where a patient had a fundoplication and they made that opening too small, and then they had to go back in and they had to dilate it so they could swallow appropriately. So that is an example of a restriction. And so if we look at this particular guideline, we have an example of a tumor embolization, and this is coded to the root operation of occlusion because the whole objective of that procedure is to cut off the blood supply to that particular vessel. But if we have embolization of a cerebral aneurysm, so this is an aneurysm in the brain, we code that to a root operation of restriction because we don't want to completely close off that vessel. We just want to narrow it at the site of that aneurysm. And remember what an aneurysm is. It's when the walls of a vessel become weakened and expands out like an abdominal aortic aneurysm. And if you don't go in and treat that, those vessels can rupture, and then of course you can have a stroke, or if it's in the case of the abdominal aorta, you can bleed to death. So when we think about restriction, we need to think in terms of somehow strengthening the walls of that vessel so that they don't continue to balloon out and then possibly rupture. So let's look at number 19. I just want to back up a few minutes in looking at my notes. I'm not sure that I went over number 18. There are two codes for that. I'm pretty sure I did, but just in case, those codes are 0, D as in dog, B as in boy, 90ZZ, 0, D as in dog, J, 08ZZ. So I'll just type them in here real quickly. So this is for the excision of the duodenum. That's a definitive procedure, so it is coded as the principal procedure. The inspection of the procedure is coded, but it is a secondary procedure. So this is the inspection of the upper intestinal tract. Okay, so going to 19. This is preoperative embolization of the right renal artery in a patient that has renal cell carcinoma in that right kidney. So obviously we're going to be in medical surgical, and the body system for this is lower arteries, because this artery is below the diaphragm. And our root operation here is occlusion, and it's the right renal artery. And this is a percutaneous procedure, and they're using an intraluminal device, and there's no qualifier. Now certainly if you had the operative report, you would know that this approach was percutaneous and that they used a device. They're not telling you that in this example. I wouldn't expect you to look at this example and be able to get right to this code with the information that is provided for you. But this is the code that is applicable for this particular example. Then for number 20, we have embolization of right internal carotid artery aneurysm. And in this case, we're talking about a restriction. So we're in medical surgical, and then we're in upper arteries for this particular example, and our root operation is going to be restriction. And then this is the right internal carotid artery, so we're choosing K. And again, this is a percutaneous procedure. An intraluminal device is used, and there's no qualifier. Now in this particular example, they would use an intraluminal device to maintain the patency of that vessel. So 03V K3DZ. Now let's go to page 128. And we have release procedures and we have division procedures. And let's go into medical surgical, and then I'm going to pick there's release and there is division, and I chose tendons because I knew that those root operations would be there. But when we're looking at root operation B3.13, the body part value that we code is the body part that's being freed up, and not the tissue that's being manipulated or cut to free up that body part. So if the purpose of the procedure is to free up a tendon, the body part's going to be a tendon. Even though they may cut the surrounding structures to free up that tendon, the body part will be the tendon, not the surrounding structure that they were cutting. So in this example, we have lysis of intestinal adhesions. And so adhesions are scar tissue, and lysis means cutting or freeing. So sometimes when patients have intra-abdominal surgery, they develop scar tissue, and that scar tissue can actually cause bowel obstructions. And so sometimes they have to go back in and free up or cut away the scar tissue that has formed to relieve the patient's pain and their obstruction. The problem with that is that they just keep coming back. So they are very hesitant to go in and start that process because it just keeps coming back. So in number 21, we have laparoscopic lysis of adhesions of the small bowel. So we'll be in medical surgical, and then we're going to be in gastrointestinal system. And then this is a release. So we're releasing that small bowel, and we know that this is via natural or artificial opening endoscopic, because it tells us that this is laparoscopic, so they're using a laparoscope. Nope. Okay, yep, be a natural. Okay, let me back up here. The small intestine, that's our body part. The small bowel is the small intestine, and then this is percutaneous endoscopic. It is not via a natural or artificial opening. I apologize for that. It's percutaneous endoscopic, and there's no device and no qualifier. So the code is 0DN84ZZ. Now, B 3.14 tells us that if the objective of the procedure is to free a body part without cutting that body part, the root operations release. We just did that. We released the small bowel without actually cutting the small bowel. If the objective of the procedure is to separate or transect a body part, it's referred to as division. So an example is if you have a nerve that is encased in scar tissue and it's causing pain, and you want to go in and relieve that pain, then that's coded to a release because you're freeing up that nerve from the scar tissue without actually cutting the nerve itself. But if you go in and sever a nerve root to relieve pain, then that's called a division. So let's look at examples 22 and 23. 22 is release of carpal tunnel, and this is a percutaneous endoscopic approach. And when you have carpal tunnel syndrome, the issue is that the median nerve, from repetitive use, people get this pain in their wrists. And from repetitive, it's kind of when their desktop is not ergonomically correct, and over years it becomes scar tissue accumulates in those wrists, and people will have what is called carpal tunnel pain, and it's because the median nerve is being compressed. So the median nerve is part of the peripheral nervous system, and our root operation is going to be a release. And it's the median nerve, and when you're reading an operative note, it will tell you specifically that it is the median nerve, and we know that this is percutaneous endoscopic, so there's no device and no qualifier. So if we go to release and try to put in median, we don't see anything. But if we go to release nerve and then median, it brings us to the table of 0, 1, and 5. And then we can choose our approach. And then it will probably default in. Let's see if it defaults in. Yep. It defaults in with everything but the approach. So 0, 1, and 5, 4, ZZ. And now let's look at a trigeminal rhizotomy. So we're going to be in medical surgical, And this is the central nervous system. You've heard of trigeminal neuralgia, and that is the nerve pain that you get in your jaw. And so this trigeminal nerve is a part of the central nervous system. And in this instance, this is a division because they actually are cutting that nerve to stop that pain. And we're choosing the trigeminal nerve, which is K. And in this instance, it's an open procedure, and there's no device and no qualifier. So 008 K0ZZ. And we can go to division. If we put in trigeminal, we don't find anything. We have to go to nerve, and then we'll find trigeminal, and it will take us to the table 008K. That pops in, and all we have to do is choose the approach. Now, the next guideline is B3.15, and this is repositioning when a patient has a fracture. So reduction of a displaced fracture is coded to the root operation of reposition. So let's go to medical surgical, and we're just going to pick lower bones and then reposition. And you can see that the definition of this root operation is moving to its normal location or other suitable location, all or a portion of a body part. So that's what you do when you reduce a fracture. You will probably never hear a physician say he is repositioning a fracture. He will tell you that he is doing a reduction of a fracture. Sometimes they're closed and sometimes they're open. But the root operation for that is going to be repositioning. Now, when they reduce a fracture, most of the time they put on a cast or a splint. But when we're using that root operation of repositioning, we do not code the application of that cast or splint separately. If we have treatment of a non-displaced fracture, it is coded to the procedure that's performed. So if we have casting of a non-displaced fracture, it's coded to the root operation of immobilization in the placement section. So you'll notice that we can go to 2, which is placement, and we pick anatomic region, and then we pick dressing, and we're just going to pick lower leg left. No, that's not where we go. We pick immobilization, and then we'll say lower leg left. External, the approach is external. That's the only option we have because we're putting on a cast, and that is an external process, and there's no qualifier. So this is an example of a cast application. Let's look at the root operation, and we see immobilization, leg, and we'll do the left lower leg, or left lower leg. And you can see that it takes us to the table, and all we have to do is choose the device. It could be a splint or a cast or a brace as part of that immobilization process. So let's look at 24 and 25. In 24, we're putting pins in a non-displaced fracture of the distal radius. And our approach here is percutaneous, so they're just popping those pins in. So we are going to be in medical surgical, and then our body system is going to be upper bones, and this is an insertion, into the right radius. Our approach is percutaneous. And pins are an internal fixation device. We have some options for other internal fixation devices, but our documentation doesn't support that. So we're going to choose 4, and then there's no qualifier. So for this example, the answer is 0, P as in Paul, HH, 3, 4, Z. And when you're putting pins in, you are working in a root operation that always involves a device. So if you look on page 111, you'll see the bottom, at the very bottom, is insertion. And that is putting in a non-biological appliance that assists, performs, or prevents a physiological function but doesn't take over the functioning of that body part. And then 25, casting of a non-displaced left radial fracture. And so you'll remember that we have to go into placement, and then we're choosing our anatomic region, and we're choosing immobilization, and this is a lower arm, casting of non-displaced left radial fracture, not right, yes, left. Okay, and then the approach is external, and we are putting a cast, and there's no qualifier. So 2W3 DX2Z. And you have a 2 and a Z right here together. If I were writing this code, I would be putting a little line through that Z so that I could differentiate it from my 2, because otherwise it looks like you could have X22. So when you're writing it, if you cannot distinctly write your number and your letter, put a line through the Z. And then finally, our last guideline is transplantation versus administration. If you have a mature, functioning, living body part that is taken from another individual or animal, it is coded to the root operation of transplantation. But if you are administering autologous or non-autologous cells, that's coded to the administration section. So there is a difference in transplant and administration, but the terminology can be confusing. So if you put in autologous or non-autologous bone marrow, or pancreatic islet cells, or stem cells, those are coded to administration. But you'll hear people say that they received a bone marrow transplant or a stem cell transplant, but those are not coded as transplants. If we go into medical surgical, and for instance, let's choose gastrointestinal and transplant, which is Y, you can see that we have body parts here. If you go into a body system and you don't see your body part, you're in the wrong body system. One thing that we often frequently see transplanted is kidneys. And on another note, Medicare patients receiving transplants have to receive them in a Medicare certified transplant facility. So you can't just have them anywhere. So if we want to look at in the renal system for a kidney transplant, it's either going to be right or left. Now, something that is really easy for transplants is to go to the index and look at transplantation. And do you see these are the organs that can be transplanted? If it's not on this list, it really can't be transplanted. And so these codes actually take you to the table that you need to be at. So we can see here's liver transplants. They're done kind of commonly. Lungs, not as commonly. I've never heard of an ovary transplant. I'm sure they probably have happened. So anyway, these are the transplant codes. Now, in this example, let's look at administration. So if we're looking at a blood transfusion, we're doing circulatory, and then we only have one root operation here, and that's transfusion. This body system region is the vessel that was used to accomplish that transplant, and usually it's, transfusion, usually it's a peripheral vein, it's percutaneous, and then you choose the type of substance. Maybe they received whole blood, and maybe it was not their blood. You know, sometimes patients donate blood for themselves before surgery. That would be autologous. But if it's not their blood, then it is non-autologous. And so typically this is the code that you would use for a patient that receives a transfusion. In our example, we are transplanting pancreatic islet cells, which are non-autologous, via a portal vein. And so we're in administration, and this is going to be a physiological system and anatomic region. It's not circulatory. And then our root operation is going to be introduction. If we look at the definition of these, we can see that introduction is putting in a prophylactic substance except blood or blood products. So that is how you would know that this wasn't where you should be for a transfusion. Irrigation is putting in a cleaning substance. So if you have a patient that has peritoneal dialysis, that would be irrigation. So we're choosing introduction. And then the route, the vessel that was used, is the peripheral vein. And this is percutaneous. It's not an open approach, it's percutaneous. And then our substance is pancreatic islet cells. So if we look down our list, we can find pancreatic islet cells down here at U, and these were non-autologous, so we would choose one for non-autologous. So our code would be 3E0 33U1. You can see what some of the other substances are, and for instance, if you're using the peripheral vein, you would not be putting in nutritional substance. You would not be putting in you would not be putting in stem cells. You would not be putting in a local anesthetic. So those things that are grayed out, and let me just take that off, those items that were grayed out are not appropriate with a peripheral vein. And so you can go through here and play around with this and see what type of substances can be introduced into these different body parts. Now, your question for this lecture is, I want you to provide me the code for a blood transfusion of platelets. So a patient is receiving a transfusion of platelets. How are you going to code that? And that will conclude this lecture, lecture 10 for Chapter 6.